So that's our big approach. We broke it down a little bit by bit. And then again, if it's none of these things and it doesn't add up to asthma or COPD, then we have to start thinking about other things. Is this cellular metabolic, neuromuscular, something like that? Which by the time we've got these other things off the list, then that can change the position of those diagnoses on our differential diagnosis. And if we look for all of these other things and we don't see any of them, this makes our differential diagnosis much shorter and quicker and easier to work through at the bedside. So when we look at someone who's short of breath in front of us and we're trying to work through the differential, ultrasound can help us quickly shorten this. If we see no diagnostic ultrasound findings, there's nothing cardiovascular, we don't see a pleural collection, we don't see any signs of parenchymal disease, then either given the clinical history and the other findings, we know, okay, this is most likely a COPD or an asthma flare, or now we've got a much shorter differential. Maybe do we need to explore other things like symptomatic anemia, carbon monoxide poisoning? Is this neuromuscular? Do they have botulism? Or is this a myasthenia gravis flare or something like that? And even if we are pretty certain this is a myasthenia gravis flare or some other less common cause of shortness of breath, knowing that it's not complicated by pneumonia or heart failure can be very helpful in focusing our treatment of that patient. So I hope you can see where even if your heart and your lung ultrasound are completely negative, this helps you in solidifying and shortening that differential diagnosis and narrowing your approach and decreasing your cognitive load in managing these patients. All right, so we talked about a lot there. We talked about how when a patient's short of breath, you can look at their heart, look at their lungs, make some immediate decisions, shorten your differential, make some important diagnoses right away, quicker than any other tests are going to come back. The first thing to remember is that your most important first step is a thorough history and physical, because that's going to give you context, it's going to focus your ultrasound efforts, and then help you integrate the findings into the whole clinical picture. Do your heart and lung ultrasound, get yourself some immediate answers, actionable information. The questions you want to try to answer: is it cardiovascular, like tamponade, massive PE, or does this look like CHF? Is it respiratory? Is there a pneumothorax? Is there a pleural collection? Or are there other infectious or inflammatory findings? Absence of those, then maybe it's COPD or asthma. Could still be a small pulmonary embolism, but not a submassive or massive one. Or is it something else? Neuromuscular, cellular, metabolic, something else. And your differential and your cognitive workload should be significantly shortened by using ultrasound early or immediately in the workup of these patients. I think that's all we've got here for approaching the acutely dyspneic patient with ultrasound. I hope that you found it helpful. And I hope that as you see patients who are short of breath, you can apply ultrasound to help you make sense of them more quickly, make your brain workload a little bit easier, and help you make important diagnoses that are going to change the course of care for your patients. And you do this enough, you're going to find things that are going to save patients' lives. I promise you that. Looking forward to seeing you all next time, and keep scanning.